Interpretation of Acid-Base Disorder Part 2. Dr. Jalal Mohsin Uddin. MBBS, DTCD, FCPS Pulmonology. The points which will be discussed here. 1. Acute respiratory acidosis, slide 3. 2. Chronic respiratory acidosis, slide 6. 3. Acute respiratory alkalosis, slide 14. 4. Chronic respiratory alkalosis, slide 15. 5. How will you differentiate between acute and chronic respiratory disorders, slide 21. 6. Compensatory changes of HCO3 in respiratory acidosis and alkalosis, slide 24. Acute respiratory acidosis. If pH is less than 7.3, more likely to be acute respiratory acidosis. pH is lower than chronic. Uncomplicated acute respiratory acidosis will not elevate HCO3 beyond 32 mg/L, normal level, 18 to 24 mg/L. Acute respiratory acidosis, pathophysiology. In acute respiratory acidosis, in early stage, tissue and red blood cells generate HCO3 by taking up H+ in exchange for Na+ and K+, ultimately resulting increased serum HCO3 and K+ level. Duration of acute respiratory acidosis is less than 24 hours. And therefore there will be no renal compensation. Tissue and red blood cells elevate serum HCO3 above 4 mg/L even with very high PCO2 level. Causes of acute respiratory acidosis. 1. Airway obstruction include A. Aspiration of foreign body or vomitus. B. Laryngospasm. C. Obstructive sleep apnea. 2. Respiratory center depression include A. General anesthesia. B. Sedative overdosage. C. Cerebral trauma or infarction. D. Central sleep apnea. 3. Circulatory impairment include A. Cardiac arrest. B. Severe pulmonary edema. 4. Neuromuscular defects include chordotomy, botulism, tetanus, Guillain-Barré syndrome, crisis in myasthenia gravis, familial hypokalemic myopathy. Drugs and toxic agents, example, curate, succinylcholine, aminoglycosides, organophosphorus. 5. Restrictive defects include pneumothorax, hemothorax, fleal chest, severe pneumonia, ARDS, chronic respiratory acidosis. pH tends to be more than 7.3, 7.3 T0, 7.4, slightly less than normal. There will be rise of HCO3 due to renal compensation. If PCO2 more than 60 mm of Hg, should not have normal pH, without other, metabolic, cause. Chronic respiratory acidosis, general consideration. Chronic respiratory acidosis persists more than 24 hours. After subsiding acute conditions, serum HCO3 rises further due to increased compensatory synthesis of HCO3. Elevated PCO2 stimulates renal tubular H+ secretion and ammonia production. As more acid, H+, is excreted, more HCO3 is synthesized and returned to blood. The high PCO2 also allows kidney to reclaim new HCO3 when filtered through glomeruli. Chloride excreted with NH4+ to lower serum chloride. Causes of chronic respiratory acidosis. 1. Airway obstruction include COPD, bronchitis, emphysema. 2. Respiratory center depression may include chronic sedative depression, primary alveolar hypoventilation, Uddin curse, brain tumor, bulbar poliomyelitis. 3. Restrictive defects include A. Obesity hypoventilation syndrome, Pickwickian syndrome. B. Kyphoscoliosis. C. Spinal arthritis. D. Fibrothorax. E. Hydrothorax. F. ILD. G. Decreased diaphragmatic movement, example, ascites. H. Prolonged pneumonitis. Symptoms of respiratory acidosis. As carbon dioxide levels increase, the brain experiences increased blood flow and volume, leading to specific impairment and associated symptoms. Moreover, persons release catecholamines produced by the adrenal glands during stressful periods and contribute to develop various symptoms. Symptoms of respiratory acidosis continue. Initial signs of acute respiratory acidosis include headache, anxiety, blurred vision, restlessness, confusion. Without treatment, other symptoms may occur. Sleepiness or fatigue, lethargy, delirium or confusion, shortness of breath, coma. Symptoms of respiratory acidosis continue. The chronic form of respiratory acidosis doesn't typically cause any noticeable symptoms. Signs are subtle and non-specific and may include memory loss, sleep disturbances, personality changes. Example: 5. A known case of COPD patient was received in respiratory echo with following report: pH 7.2, PCO2 74 mm of Hg, HCO3 27 meters EQ, L. Acute respiratory alkalosis. In acute respiratory alkalosis, the PaCO2 level is below the lower limit of normal and the serum pH is alkalemic. If pH is more than 7.5, more likely to be acute respiratory alkalosis. Chronic respiratory alkalosis. It is a common acid-base disturbance characterized by a primary and sustained decrease in arterial carbon dioxide tension, PaCO2, that is, by primary hypocapnia. A decrease in PaCO2 occurs when the effective alveolar ventilation increases to a supernormal level. pH slightly higher than normal, usually less than 7.5. Can have normal pH when process is going on more than 2 weeks. HCO3 falls due to renal compensation but not below 15 mEq, L, normal level, 18 to 24 meters EQ/L, in the absence of metabolic acidosis. Respiratory alkalosis is a disturbance in acid and base balance due to alveolar hyperventilation. Alveolar hyperventilation leads to a decreased partial pressure of arterial carbon dioxide, PaCO2. Causes of respiratory alkalosis. Hypoxia. Decreased inspired oxygen tension, example, high altitude area. VQ inequality. Hypertension. Severe anemia. Voluntary hyperventilation. Neurological diseases, CVD, encephalitis, meningitis, trauma, tumor, stress, fever, hyperventilation due to cardiac disorder, improper mechanical ventilation, pain, drug use, fever, infection, pulmonary embolism, pregnancy. Symptoms of respiratory alkalosis. The chronic form is asymptomatic, but the acute form causes lightheadedness, confusion, peripheral and circumaural paresthesias, cramps, palpitation, convulsion, sweating and syncope. Signs include hypopnea or tachypnea and carpopedal spasms. The lightheadedness and syncope are felt to be a result of the decrease in cerebral blood flow that is caused by hypocapnia. The paresthesias, tetany, and seizures are thought to be related to the decrease in ionized calcium that occurs because alkalemia causes more calcium to bind to albumin. Rebreathing within a close sac to increase PCO2 in blood. Example, 6. A case of LVF was admitted in CCU with following report. pH 7.48. PaCO2 32 meters m of Hg. HCO3 22 meters EQ/L. How will you differentiate between acute and chronic respiratory disorders, acidosis or alkalosis? A. In acute respiratory acidosis or alkalosis. 1. Change in pH equals 0.008x change in PCO2, that is, for each 10 change in PCO2, the pH will change by 0.08. 2. Formula 5, change in H+, greater than or equal to 0.8. Change in PCO2. It means there is acute change in PCO2. Formula 5 can be calculated from Formula 4. How will you differentiate between acute and chronic respiratory disorders, acidosis or alkalosis? Continue. B. In chronic respiratory acidosis or alkalosis. 1. Change in pH equals 0.003x change in PCO2, so, with each 10 change in PCO2, pH will change by 0.03. 2. Formula 6, change in H+ less than or equal to 0.3. Change in CO2. If the result is less than or equal to 0.3, then it will be chronic respiratory acidosis or alkalosis. If change in H+ divided by change in CO2 equals between 0.3 to 0.7, that indicates acute on chronic respiratory acidosis or alkalosis. In chronic respiratory acidosis or alkalosis, most likely the pH will be between 7.3 to 7.5. Compensatory changes of HCO3 in respiratory acidosis or alkalosis. Clues for the presence of mixed disorders. Ranges of compensation is more in chronic cases, as kidneys are getting more time for compensation. If compensation of HCO3 occur more than the higher value of normal range, there should be associated metabolic alkalosis. On the other hand, if HCO3 is less than the lower limit of normal range change, there may be associated metabolic acidosis. Example: 7. Question: in a post-PT fibrosis patient of ICU, pH was 7.37 and PCO2 was 50 of Hg. After development of nosocomial pneumonia, he developed shortness of breath and his pH became 7.47 and PCO2 became 30 mm of Hg and HCO3 was 22 meters EQ/L. What type of acid-base disorder was developed? Step 1. At first check the internal consistency of the report. By utilizing the linear relationship between pH and H-ion concentration, we can measure H-ion concentration from pH. Here pH is 7.47, so H-ion concentration will be 40 to 7 equals 33 nanoequivalent per liter, NX/L. Ref. Interpretation of acid-base disorder Part 1 Example: 1, Slide 8. To see the internal consistency we can use Henderson-Hasselbalch equation. H-ion concentration equals 24 multiply PCO2 divide by HCO3 equals 24 multiply 30 divide by 22 equals 24 multiply 1.37 equals 24 multiply 1.37 equals 24 multiply 1.37 equals 32.88, which is almost equal to measured H-ion concentration, that is 33 now equivalent per liter NX/L. So, the ABG report is internally consistent. Ref. Interpretation of acid-base disorder Part 1 Example: 4, Slide 21 and 22. Step 2 Whether it is acidosis or alkalosis? It is alkalosis as pH is more than 7.45. Step 3 Whether it is respiratory or metabolic? Here PCO2 is 30 meters m of Hg, that means it has decreased than the normal level, but HCO3 concentration is 22 meters EQ/L, which is within normal limit. Change of PCO2 correlate with pH value. So, the primary disorder is respiratory alkalosis. Ref. Interpretation of acid-base disorder Part 1, Slide 26. Step 4. Whether it is acute or chronic disorder. Change of pH is 7.47 minus 7.40 equals 0.07, so change of pH is nearer to the 0.08 can be considered as acute change. So it is acute respiratory alkalosis. Step 5. Whether there is compensatory change. HCO3 decrease, 24 meters EQ, L minus 22 meters EQ, L, equals 2 meters E, L, so, there is compensatory reduction of HCO3. Ref. Interpretation of acid-base disorder Part 2, Slide 24. Step 6. Is there any mixed disorder? Change of PCO2 is 40 minus 30, equals 10 millimeters of Hg. We know for each 10 millimeters of Hg, in chronic respiratory alkalosis there should be reduction of 2 meters EQ, L of HCO3. So here change is within the range and therefore there is no mixed disorder. So it is a simple acute respiratory alkalosis with renal compensation. Ref. Interpretation of acid-base disorder Part 2 Example: 1, Slide 24. Step 7. Whether it is partial compensation or complete compensation. It is partial renal compensation because HCO3 reduced but pH is still high. So, it is a case of simple acute respiratory alkalosis with partial renal compensation. Ref. Interpretation of acid-base disorder Part 1 Example: 1, Slide 28 and 29. Thank you all. End of Part -2. Learning Pulmonology.